for them. Now, something that we think is really, really important. So important that we want to spend 5 or 10 minutes right now kind of putting on a little play for you to show you actually how we would do it. Now, I want to tell you a little bit about the people who are going to do this with me here, and review ahead of time a couple of the reasons why we want to do it, and some of the special circumstances that you may actually find yourself in as you do this. So the tabletop simulation, which is what we call this because we encourage you to do it around the table, is something that's easy to do. It checks the checklist that you're proposing outside of the operating room, so there's none of the pressures of time or hurting a patient or embarrassing yourselves in front of anybody as you take it apart and put it back together. It doesn't take a lot of time to do this. You could learn a ton from it about whether or not it'll work in your hospital. And testing the checklist on a small scale like this can prevent you from making big mistakes. Now, you're going to hear me say it a bunch, saying those words. Small scale testing avoids big scale problems. Or test small and keep your mistakes small. And there's a reason, big reasons for that. The tendency in healthcare is for us to think we're the experts, and in a lot of things we are. But probably one of our biggest failings is that we make up something, a form or a tool, in isolation, and then instead of trying it out to make sure that it actually works, we just go ahead and put it out. If you do that with the checklist, it will fail in your institution because there will be problems. And it is absolutely important that you test it, not once, not twice, but a bunch of times. And the very first testing goes on like this, and it's a tabletop. So here you can see in a conference room or an empty operating room, a group of people sitting around the table. You can see that in this particular case, we took our administrator and carrying the smartphone there, and put our administrator on the table as a patient, and then scattered the rest of the team around the room. So there is a surgeon and a scrub nurse and the anesthesiologist and the circulating nurse. And you do this in a conference room, or you can do a dry run in an empty operating room if you can get one. But the whole idea is do it. Do it out away from a real patient. And do it before you ask anybody else to do it to make sure that it works out okay. So, this is a group actually that we put together to show you us doing it in a different setting with a different group of people. Actually, some of whom have gone back to their residencies and aren't part of our team anymore. But we have, because of for practical reasons, we have a different team with us today. And I have a surgical resident, one of the fellows here who is actually actively involved in the South Carolina project with us, Leon, who's going to play the role of the anesthesiologist today. Lizzie, who most of you have heard from already, either on a call or in an email, is going to play two roles because, like many meetings, not everybody showed up for this one. So Lizzie is going to be the scrub nurse and the circulating nurse. And when Lizzie told us what her background was, her background does not include nursing. So we're going to wing it a little bit, but still try and be as authentic as we can be. And although I haven't done the operation that we're going to talk about for a long, long time, I'm going to try and fake being the surgeon. But remember, the idea isn't to do a perfect job. The idea is to test the checklist out. And as we go through this, if we make mistakes, we may even stop part of the way through and talk about what it is that we need to change. Or we may do it perfectly to our satisfaction. No matter what, we're going to stop and talk at the end a little bit about how it felt and what we might want to think about doing a little bit differently. So why don't we get started? Are you guys ready?
Yep.
So here's our patient for today, and I'll introduce him to you. His name is Mr. Mark Wohlberg, and he is a 68-year-old gentleman, and he's a healthy guy with a relatively straightforward operation, a right inguinal hernia, and he's going to have a right inguinal hernia repair. And we are going to use as our checklist that we're working on here and modifying the South Carolina Surgical Safety Checklist template. So let me put that up for you. We've modified it. Our first modification, the only significant one we made so far, is that we changed it and it's Harvard Hospital's Surgical Safety Checklist. So up here at Harvard Hospital, which, believe it or not, there isn't one of those here at Harvard. None of them are called Harvard Hospital, but that's the name of our hospital here at the School of Public Health. And we're going to go ahead and run through the checklist for you. And remember now, we're doing it to test it out. So, you guys ready?
We're ready.
Everybody ready? Let me move the telephone a little bit to get it in front of all of us. And we're going to go ahead and run the checklist for Mr. Wohlberg. So, it's all yours, guys.
All right. Let's start with the before induction of anesthesia check. All right. Our patient is Mark Wohlberg. His date of birth is 12/8/1943, and the surgical site is a right groin. The surgical procedure to be performed matches the consent.
That's correct. Right inguinal hernia repair?
Yep. That's what I have. And the site has been marked by the surgeon.
Looks like it.
I don't have any, Mr. Wohlberg doesn't have any known allergies. Right?
Yeah, no known drug allergies.
And has the anesthesia safety check been completed?
It has, and I think the next part is mine. The anesthesia, let's see. So I will discuss with you the specific information. So anticipated airway or aspiration risk, I don't anticipate to have any problems. We'll use endotracheal tube. Risk of significant blood loss. There shouldn't be much blood loss in this operation, but I do have 2 peripheral IVs in place. I don't think we need any blood available, and I don't think we need a tightened screen for this operation. Risk of hyperthermia or operation greater than 1 hour. I don't think it'll take Dr. Berry more than an hour, but we'll use a bear hugger, upper body and lower body. And risk of venous thromboembolism. We do have the STDs in place, but I don't think we'll need the heparin.
Great. I think we're ready to go.
Sounds good.
Okay, so the prep is going to take place, and the positioning of the patient, and the surgeon comes into the room, and now it's time to do the before skin incision portion of our modified surgical safety checklist. So for this portion, I guess I'll go ahead and run it. I'm Dr. Berry, the surgeon, and so the patient's name is Mr. Mark Wohlberg. The surgical procedure to be performed today is a right inguinal hernia repair using mesh. The surgical site is the right groin, which I previously marked. The patient is appropriately positioned and is supine, and I don't need any special imaging available for the case today. Has antibiotic prophylaxis been given to the patient within the last 60 minutes?
Yes, I gave Capsol about 15 minutes ago.
And I don't think we need to plan for redosing because the case should be short enough that we shouldn't need to do that. Now I'm going to go ahead and move to the briefing section. Why don't we go ahead and go around and all introduce ourselves. I'm Bill Berry, and I'm the surgeon today.
I'm Lizzie Edmondson, the circulating nurse and scrub tech.
And my name is Liam Huang, and I'm the anesthesiologist for today.
Okay, well, let me take my part of the discussion then. The plan today is an open repair of a right inguinal hernia, and I'm planning on using mesh. I'm not planning on encountering any difficulties. This is a first-time repair. I expect that the operation will take less than an hour to perform. The anticipated blood loss is minimal, and I'm going to need the mesh that I usually use for these operations, Lizzie?
We have it.
Fantastic. Liam?
Okay. I think our anesthetic plan will be our usual, using general anesthesia, and I'm planning on doing an intubation for this operation.
Great. And we checked the sterility results, and everything's correct. And I think we have all the equipment that we need.
So before we get started, does anybody have any concerns? No? No concerns. If you see something during the case that concerns you, please speak up. So the patient has the operation, things go well, they come to the end of the operation, and it's time for the patient to get ready to leave the room.
All right. We just did the instrument, sponge, and needle counts, and they're all correct. The name of the procedure is a right inguinal hernia. And I have a specimen for Mark Wahlberg, date of birth 12/8/1943. And what is the tissue?
The tissue is a hernia sac. And could you record the name of the operation as right inguinal hernia repair with mesh?
Sure. Okay. And were there any equipment problems that need to be addressed?
None that I noticed today.
None on my part.
Okay. And what are the key concerns for patient recovery and management?
From the standpoint of the operation, I'm expecting a routine recovery for somebody who's had a hernia. Liam, any problems with anesthesia?
Nope. He's been great throughout the entire case, and shouldn't have any problems going home after this.
All right. And could we have done anything better to make this case safer or more efficient?
I think it went well.
And I don't think so. I'd like to thank everybody for helping do a great case.
All right.
Thank you.
So, now we're done. We ran through it. We felt what it feels like. We read the words on the paper, and now we ought to spend a little bit of time debriefing. Lizzie, any thoughts?
I thought a lot of the wording was awkward, and that it should actually be questions and not statements. I was translating everything in my head.
Yeah, I'd agree. Maybe it's just because I haven't read through this before, but it just feels like it takes time and I have to read the entire thing.
Yeah.
Yeah, and I'm not sure about the way the surgical safety statement reads. I think that I need to spend a little time thinking about that. Those words don't feel right to me either. And actually, I'd like to talk to a couple of the surgeons about how they would say something like that. And make it comfortable for them, because again, it felt a little bit weird. But so now I'll close all that out, and we can go back to talking about modification. But I wanted you to hear what it can sound like, to show you how easy it is to do it, that it doesn't take a whole long time to get it done, and that you can learn a lot by going through and trying out your modifications by saying them out loud with other people, role-playing around a table. And again, it can save you so much heartache if you can work out the bugs like that rather than doing it in the operating room. And remember, your job in the modification process is, again, to make it work for your hospital, to make it work for most of the people that are there. So the barrier for them using it isn't that it's a bad checklist or that it doesn't work or it doesn't respect your facility. You really want to make it as good as you can before you show it to anybody else.